Thank you, everyone. And also, for those of you guys that organized this, thank you so much. I feel like we're all in conversation with one another with our research and our work, and this is just really exciting. I'm Andy. I'm going to be presenting the results of a qualitative study on the impacts of racism and bias on patient experience. So we know that minoritized communities bear the brunt of inequities in health outcomes and social needs. And we've seen a burst of energy in addressing social needs as a strategy to address health inequities. And as such, we're seeing social needs screening and social needs interventions in healthcare settings across the country. Now, this is interesting because, we've talked about how in some ways what we're doing sort of has outpaced the evidence, and we're just getting more good evidence around patient experiences, and yet few studies really focus on the experiences of minoritized patients in social care. And this has real implications for intervention design, metrics, and evaluation. And so what did we do? We conducted a qualitative study to better understand the role that race, racism, and bias may play in patient experiences of healthcare-based social care. And here we define healthcare-based social care as simply social care along the continuum, whether it's screening, referrals, resource delivery, that is based in a healthcare setting and starts out in a healthcare setting. So we conducted a qualitative analysis of 25 semi-structured interviews with patients who were adults, had experienced healthcare-based social care in the last 12 months in any healthcare setting, and spoke Spanish or English, and were from a racial and ethnic minoritized group historically. We did convenience and snowball sampling. We distributed a study flyer nationally using our listserv in several contexts. Our interviews were double-coded, and we conducted a thematic analysis of patient experience. Our interview guide really tried to suss out what patients' experiences were at every single step of social care, whether it was the screening portion, how did you feel, who did that for you, why did you feel that way, or during the referral process or follow-up or lack of follow-up. And we also asked patients specifically, did you feel like your race, ethnicity, or gender impacted your experience in some way? And we coded accordingly. So these were our participants. We had 25 participants, 36% were Black or African American, 64% were Latinx, 56% were primarily Spanish speaking, and folks came from a variety of urban of cities across the United States. And most participants really told us about their experiences of social care that were based in primary care outpatient settings. And so what did we find? The too long didn't read results page. So we found that systemic, structural, and interpersonal racism were important factors in our participants' experiences of social care. And just to really break this down for us, we found that stigmatizing narratives around race, poverty, welfare, and government services were really front of mind for Black and Latinx participants and really fueled sort of distrust or threat appraisal and some of the things that the other presenters noted. We also found that participants really recounted their previous experiences of racism and bias in medical care throughout healthcare delivery and fueled their distrust in healthcare-based social care. And this distrust and these experiences and actual experiences really led participants to disengage from social care. So participants described not disclosing social needs on screening. They described rejecting offered services for their actual social needs. And at the same time, and this goes back to some of the previous work that you guys had presented, folks really described the things that promoted trust and really led to positive experiences of social care. And just to go through each of these a little bit more. So this participant says, I'm a new patient. I've never met this person. I'm filling out all this information. Am I going to be judged by this? Is this going to impact the way my doctor feels about me? And we heard this a lot. I didn't want to be another stereotype. I don't want to be another stereotype. I'm afraid of answering these questions. And we really saw this transfer of distrust from medical care and experiences with the healthcare system transferred to healthcare-based social care. So this participant says, my last experience with screening was when I had my baby. Immediately, they wanted to do surgery to tie my tubes. They lectured me, you don't work and your husband has 2 jobs. You end up casually sharing things, but in the end, they use that to attack you. This was a very common theme along our Latinx participants and their experience with obstetrics and pregnancy care. And it's easy to understand how this would be the case, but participants described really disengaging from healthcare-based social care and being afraid to engage. And they would say that they would withhold social needs during screening, even if they had social needs, and declined to offer services for their social needs. So for example, this participant states, the question with this initial social worker, it was very biased, the way she would ask the questions. I said, well, I think I'm good. I don't think I want to answer any more questions. She just wasn't sensitive. And this echoes a lot of what's been presented before. And then this participant says, when the social worker was called in, the first thing I felt was fear. I was thinking, they'll take my children away from me. They'll say I have postpartum depression or something. I was so afraid that I took the pain medication. I went home and I never went back. And this echoes a lot of what we seen from the PEDS literature and caregivers and social needs. And these are some of the things that our participants really said promoted trust and led to positive experiences with social care. So race, ethnicity concordance, cultural concordance with their social care provider, whether that provider was their primary care doctor doing the screening or the community health worker doing the screening or resource delivery, language concordance and resources, cultural humility, and long-standing longitudinal relationships with their team. So for example, this participant says, I felt very comfortable. There's a lot of staff and personnel that identified, looked like me, that sort of thing. In the suburbs, I probably would have had a different experience. And this participant, and this is the kind of thing that we heard a lot too, was the first one had me feeling like I was just some welfare case off the street. I will say I do believe that race played a role. The second lady was a Hispanic lady. She was just a lot more culturally sensitive. I do feel like she was being respectful of my culture, and it was a gleamingly different experience. So what does this mean for us? Our findings are that racism and bias deeply impacts our patients, our participants' experiences of healthcare-based social care, and this implies that we as healthcare providers, we're not entering the space with a clean slate. And without attention to this, we really risk further entrenching distrust. Our data also point to something interesting, which is that this disengagement that seems to be very prominent and present may impact the accuracy of our screening rates and linkage to service rates. And those are not things that are necessarily picked up by the metrics that we use now. And this might actually represent a significant barrier to our efforts to use social care as a health equity tool. And so just to really hammer this home, this is the CMS inpatient quality reporting metric. Hospitalized patients, or hospitals are now required to report on their social screening activities. They're required to report what % of hospitalized patients are screened for health-related social needs. And let's pretend, this is just a little example, let's pretend that, I work at San Francisco General. 80% of my patient population is either Black, African American, and or Latinx, and immigrant. And, last year, 30% screened positive for a health-related social need. Now, 2025 happens, Project 2025 happens. Next year, we look at these metrics and it's 10%. 10% screen positive. What does this mean? Do we know what this means? There are some clues that we need to be looking under the hood a little bit more. And just in terms of wrapping it up and recommendations, our data really show that we have to prioritize trust-promoting factors in intervention design. Rebecca was talking about how, the who is doing screening, how they're doing screening, how they're describing the why of screening is really important, and our data really reflect that as well. For our evaluation efforts, there's been some incredible presentations on implementation efforts and evaluation. this really calls for looking under the hood and really looking at patient experience, and really making sure to assess differences in implementation outcomes and experience by race and ethnicity. And also at the policy level, maybe patient experience measures need to counterbalance these volume-based metrics. Some of these raw numbers and these volume-based rates are not going to give us the information that we need. These are my acknowledgements. Thank you so much to Kaiser Permanente also for funding our work, and PAF, Rebecca's organization, for all the help. Yeah, thank you. Actually, can I say something real quick? I have to say, this is related a little bit to some of the comments that were made at lunch today, and I think some of, there were some troubling comments that were made that I don't necessarily agree with, and I think if we are to continue this work in this time, if relationships and trust are so important to what we do, we have to prove to our patients that we are trustworthy. Mm-hmm. And that means when the target is on our backs, not just necessarily on our patients' backs, that we fight and that we don't abandon health equity. Yes. This is central to our work. Anyway, sorry.